Everyone, and thank you for joining us this evening for week 6 of the RISE Institute and Rugby Research Injury Prevention Group 2025 Journal Club. We will begin our first Journal Club presentation with our first intern, Natalia, and she will be presenting on a new characterization of acute traumatic brain injury. Natalia, may you please share your screen?
Thank you so much. Good evening, everyone. My name is Natalia, and I'm a rising senior at Villanova University, and I will share my screen now. Today, I will be presenting about a new characterization of acute traumatic brain injury, and this is a classification and nomenclaration initiative. So, to give a brief introduction, traumatic brain injury, also known as TBI, is a major cause of deaths and disabilities across the world. Each year, nearly 50 million people sustain a traumatic brain injury, highlighting the need for accurate diagnosis and appropriate treatment. Traditionally, this is diagnosed using the Glasgow Coma Scale, which measures a patient's level of consciousness. It is classified into three categories: mild, which is scores of 13 to 15, moderate, which is scores of 9 to 12, and severe, which is scores of 3 to 8. While this system has been used as a clinical standard for a very long time, it does have some limitations. The scale alone does not fully capture the complexity of brain injuries, which is why these researchers have looked into possibly introducing a new method. So the article specifically focuses on acute brain injuries. An acute brain injury is an injury caused by an external force, and the acute phase refers to the first 24 hours after the injury happens, which is when rapid evaluation is necessary. During this time, clinicians typically determine how severe the injury is and make immediate treatment decisions for the patient's recovery process. So, the study objective and design. The goal of this study was to develop a new multi-dimensional framework for classifying acute traumatic brain injuries that goes beyond the traditional scale. The authors wanted to also create a standardized way to improve clinical assessment, communication, and research consistency. This was an international consensus initiative, meaning it was not a clinical study or trial, but a project where experts came together from many different disciplines and reviewed different articles, evidence, and worked together to reach an agreement for the best approach for classifying acute TBI. The initiative included 94 experts from 14 different countries, and there were neurosurgeons, emergency physicians, rehab specialists, different experts, and a very key factor, there were individuals who have experienced TBI in this panel as well. The recommendations were developed through a systematic literature review, and there were regular scheduled meetings between the years of 2022 and 2025 to come up with this new framework. So, what was the framework that they came to develop? They developed one that has four different pillars that looked at different aspects of acute brain injuries. The first one is clinical, which followed the same scale that was previously used. So that was not a change in what was previously done. What they added was biomarkers, which measures blood proteins, which can indicate brain damage and improve diagnostics. They also added imaging, which uses CT scans and MRIs when it's appropriate to identify the type, location, and extent of a structural brain injury. And lastly, they looked at modifiers, which were additional factors such as age, medical history, social and environmental factors that might be overlooked when assessing a brain injury. So next I will go into each of the four pillars that they implemented. This first slide focuses on the clinical and biomarkers. So the classical clinical component, which is something that wasn't changed, this was the original scale that was used, and you can see it goes from 3 to 15. and that they didn't really change anything to it, but just added on. The biomarker pillar uses blood-based proteins released after a brain injury, and the three recommended biomarkers are GFAB, UCHL1, and S1OOB. Elevated levels of these proteins indicates brain damage and helps determine whether a CT scan or an MRI is needed. Next are the two other pillars that they looked into, which is imaging and modifiers. The imaging pillar primarily uses CT scans and MRIs when it is necessary in more severe cases to identify the type, location, and extent of the brain injury. The documents find whether there are fractures, if there's hemorrhaging, contusions, and other traumatic injuries to the brain. These findings help determine how severe the injury is because sometimes by going off the scale, it might be less severe than it comes off, or more severe than it comes off. And then lastly is modifiers, which recognizes that recovery is influenced by more than just the brain injury itself. It includes injury-related factors, such as mechanisms of the injury, but also the secondary factors, including age, medical health, if people have prior brain injuries. So in our case, concussions are a very common one. And then also community and social factors, whether the individual is supported, can all influence how their healing process is. So the results of the study were that the new pillars definitely helped characterize acute brain injuries into a more detailed approach. Compared with the original scale that they used, it just allowed for a more comprehensive assessment and allowed for clinicians to give a better understanding of how severe the injury is and how an individual's process might differ from one another. The image on the screen shows a patient that has a lower GCS score, abnormal biofactors, CT scan evidence of hemorrhaging and contusions, and additional factors such as a history of TBI and mental health conditions. This shows how the CBI framework works and how it provides more details than just a number of how severe the injury is. The framework is also designed to improve clinical decision-making and help classify patients for future studies. Although this does provide a more in-depth decision of how severe the brain injury is, it still does need validation and field testing to be fully implemented as a primary solution. Going into the strengths and weaknesses of the article, one of the biggest strengths of the framework was its multi-dimensional approach and how it looks at many different factors rather than just one scale. It includes clinical findings, biomarkers, imaging, and those outside factors that can really impact the healing process. It was also developed by an international panel of experts as well as individuals who lived with TBI. So it does include a very wide, knowledgeable group of people. For the limitations with anything, there are always some things that can be improved. In this specific case, the framework is based on expert consensus rather than clinical validation. So that means there was no direct field testing on this strategy. Additionally, biomarkers are not available in every single hospital yet, and it can be expensive to implement that. And lastly, their study specifically focused on the acute phase, which is less than 24 hours. They did not test if this could be applied after. So there would need to be additional testing in that regard as well. And then lastly, just some key takeaways. The traditional scale alone has important limitations and is no longer enough to fully characterize a brain injury. The proposed framework that they came up with includes four different pillars, which are clinical, biomarkers, imaging, and modifiers, and these do provide a more comprehensive assessment. While this approach can provide more information, there still needs to be a lot more testing done on the field on whether this is a new and sustainable approach. Here are my references, and that is all. Thank you.
Thank you for that excellent presentation, Natalia. Are there any questions, or do Dr. Lopez, do you have anything else to add? Brendan?
I just have a question. Did the experts have any did the researchers screen the experts in any way, or did they explain how they specifically picked those 94 experts for the panel?
It didn't specifically say. It was a pretty wide group, and it included people who have been looking into this this topic, but there wasn't an exact screening for who was qualified for the study and who was not, especially with for the individuals who had TBI, there wasn't like a full screening that they went through.
Thank you.
Yes, of course.
Jordan?
Hi, good job on your presentation.
Thank
I
you.
was just gonna say this is a really hard topic, and I was wondering if there's anything you found along the way that kind of changed your mind on something you previously believed, or anything like that.
I guess something that I thought was interesting was with the original classification with the scale. I thought it was interesting that that was just the traditional scale that was used, and typically, after they give you a score, they don't always do additional testing based on what score you get. And with the research, there has been evidence proven that sometimes people don't have a severe case, but once imaging is done, it comes up to be a lot worse than it is. So I thought that was really interesting and that there isn't a more like I guess that it is so simple currently. I thought that was just quite interesting. This was the first time that I looked into this specific topic.
Yeah, thank you.
Of course.
Dr. Lopez, do you have any other inputs?
Yeah, great. Thank you so much for the presentation. And again, it is very difficult to categorize and organize the classifications and nomenclature of various topics. I mean, it just varies when they put these luminaries together to categorize these definitions and the proper terming of things. It's important overall for the application and the big picture of things of how I guess to standardize the actual data. The standardize the terms, the definitions, classifications, how you're looking at them, and then avoiding any this varying you know uh I guess inappropriate classifications of the naming.
Yeah,
It's a tough topic.
yeah, and one of the things that they really thought about was the way that it's categorized right now as mild, moderate, and severe. They thought that was not an appropriate way to classify it. They didn't fully come up with a new system of how they would classify it, but they added those additional pillars to make it a little more of a wider approach rather than putting people in different categories based on one test.
Correct. Thank you so much.
Yeah, of course. Thank you.
Thank you, Natalia, for that really insightful presentation, and thank you for everyone's input. Our next intern to present is Erin, and she will be presenting on sleep optimization in athletes. Erin, can you please share your screen?
Thank you for the introduction. I will share my screen. Okay, so the journal article I'll be presenting on is called Dim Light, Sleep Tight, and Wake Up Bright, Sleep Optimization in Athletes by Means of Light Regulation, and it's by Knufink and her colleagues, and it was published in the European Journal of Sports Science in 2021. So in the introduction of the article, it talked about how athletes need relatively more physical recovery than the average person. And given that adequate sleep is necessary for recovery, it would be optimal for athletes to have good quality sleep. But in fact, athletes often have poor sleep, and this can be connected to the circadian rhythm, which dictates the timing and consolidation of sleep, which basically means like how seamless your sleep is and making sure there's no like interruptions in your sleep. Um, and in order for a person's circadian rhythm to be synced to the 24-hour sleep-wake system, light is used to help us wake up, and an absence of light is helpful to allow us to produce melatonin and feel sleepy. And some factors of these types of light are the intensity, duration, and wavelength. So some challenges to our circadian rhythm are that when we wake up, we often have insufficient light exposure because when we wake up, we're only exposed to low static indoor light. And at the same time, at night, there's a lot of light pollution. So we our melatonin is often suppressed, especially with the presence of electronic devices. They emit blue-green light, which is like short wavelength light, and that also may suppress melatonin secretion and result in increased alertness. So the purpose of this study was to determine whether light regulation can improve sleep in recreational athletes and lead to more uninterrupted sleep. Because oftentimes in athletes, the timing of exposure to sunlight is disrupted because of the factors I talked about before, but also because of variable training schedules, competitions, social media, and electronic use. So here were the methods of the study. The participants were recreational athletes who had healthy BMIs and were physically active. And the journal defined recreational athletes as athletes that were non-competitive or were competing at a local level and were participating in sports or physical activity on a weekly basis. And there were a few requirements that were put in place for these recreational athletes. First, they were all given a fixed sleep-wake pattern. So they all slept around 7 to 8 hours each night, but they weren't allowed to have more than 30 minutes deviation in bed and rise time. So that just means they couldn't stay in bed for more than 30 minutes than they were supposed to, and they couldn't go to sleep more or less than they couldn't go to sleep um like later than 30 minutes than they were supposed to. And also, they were capped to 6 caffeinated drinks per day, and the experimental weeks across individuals were scheduled to match in terms of environmental and daily stressors. And so there were two experimental weeks. So the control was no light regulation. So in the morning, they had no specific glasses, and at night, they only wore clear glasses. And then for the other week, which is the light regulation week, they in the morning they had 30-minute light emitting goggles, which are these blue-green light goggles. And that was supposed to help you wake up. And then at night, they were supposed to wear 3 hours before they went to bed, evening light restriction goggles, which are right here, and they're amber lens glasses, so they're supposed to block out any blue-green light. And then for data collection, first wrist-worn actigraphy was used. So this ActiWatch was used, and it's basically like a smartwatch, but it's more for it's like a medical grade watch, so it's more used for like scientific purposes. And these were the factors that were recorded. So for the objective sleep estimates, they wanted to track sleep onset latency, which is the exact amount of time it takes to transition from full wakeness to the lightest stage of sleep. And then wake after sleep onset, which is the opposite. So it's the total amount of time you spend um you spend awake after initially falling asleep. And then the total sleep time, and then the sleep efficiency, which is like the time you're sleeping over the time you're actually in bed. And then um, for subjective estimates or other results, they use the consensus sleep diary, which is just like an online questionnaire. And so the subjective sleep estimates were looking for the same factors as the objective ones. And then also they tracked subjective sleep quality using scales from 1 to 10. So they tracked sleep quality, refreshment, so like how refreshed you feel in the morning, and then also alertness or sleepiness, so how groggy you might feel in the morning. And then for results, there were actually two data sets because if you remember, in the methods section, in the requirements, you weren't allowed to deviate from your sleep-wake schedule by more than 30 minutes, but there was low compliance in that rule. So there were two data sets. There was a strict data set for those who strictly followed the sleep-wake schedule, and then there was another data set for those who went over but were still within a 120-minute buffer. And then the results were that sleep quality was fairly poor because the average sleep efficiency was below 85%, even though everyone slept 7 to 8 hours per night. And there was no significant difference between the 2 weeks in the actigraphy sleep estimates. So there was no significance in like the other objective sleep estimates. And then, however, in the subjective reports, there was faster sleep onset latency in the actual experimental week for both data sets. So in the strict data set, there was it was 17 minutes shorter for the sleep onset latency, and then for the lenient data set, it was 8 minutes shorter for the sleep onset latency. And for the other subjective estimates, there was no other significant values. And then finally, for the sleep quality, in the strict data set, there was actually better subjective sleep quality. So from a scale of 1 to 10, it increased from 6.63 to 7.05. And then here are some limitations and takeaways from the study. So, although the goggles were easy to use, many of the participants rated them as uncomfortable and also having poor appearance. So that could lead people to not really want to wear the goggles as much. And in fact, a lot of the participants deviated from like the requirements they were supposed to fulfill. So many people didn't reach the 3 hour mark, like before they went to bed, for example. And there were also symptoms. So some people reported having headaches or blurry vision or nausea and dizziness upon wearing the goggles. And then another limitation was that there could have been biased subjective sleep ratings. So the study mentions how um, the subjective questionnaire was filled out when as soon as people woke up. So due to sleep inertia, people could feel more groggy than they actually would, and that could mess with like the sleep quality that they reported. And also another limitation was that some of the participants could have already been believers of the intervention, so they could have gave better scores because they already believed that this intervention would work. And then another one is insufficient alignment of the circadian rhythm to the sleep schedule. So the study mentioned that, um, especially for the lenient data set, there wasn't enough light, uh, light scheduling for there to be a big enough impact to fully change the circadian system of people because it takes a really long time for the light to take into effect. So the study mentions that it could have just been placebo. And then the last limitation is that the they in the study they used the combined effects of morning light exposure and evening light restriction. So they couldn't really tell individually how impactful each goggle was. And then some conclusions are that, well, from the results, light regulation showed to be effective in shortening self-reported sleep onset latency. And with a strict sleep-wake schedule, the subjective sleep quality improved. So that could be really useful for athletes that are going into competition and helping them feel confident enough. And then something else that the study mentioned at the end was that the practical implementation was problematic because not only did a lot of people rate the goggles as uncomfortable, in real life, people's schedules are very variable. So like I said, it's very difficult to get people to wear the goggles for 3 hours before they go to sleep, and there's just difficulty in scheduling. So, and also, a less obstructive method could be researched. And yeah, this is the article. Thank you.
Thank you for that fantastic presentation, Aaron. Does anyone have any questions, or does Dr. Lopez, do you want to add anything else? Let's start with Hunter.
Thank you, Aaron, for that presentation. I've heard a little bit about this in the past and I've heard videos about using blackout curtains or exposing yourself to the like 30 minutes of sunlight in the mornings to kind of mimic this. Do you think that would be more practical? And if an experiment was done with this over a longer period of time, there would be similar or greater effects in the increase of sleep quality?
Yeah, I think like you mentioned, like the blackout curtains seem more practical. Um, but yeah, I would definitely like to see a study on that, just like with a longer period and stricter regulations put in place. But yeah, I think it could be useful because just looking at this study, like the results were promising. So if more research could be done, I think we could get a closer answer.
Yeah, and then kind of following up with that, did the article talk about why they chose to use these goggles instead of a more practical, more applicable method like blackout curtains, or was that not mentioned?
That wasn't really mentioned. I mean, I think the just based on the introduction, they were alluding to the fact that about like different wavelengths of light, like people being exposed to like blue-green light or having like more red light. So I think that's what they wanted to test mostly. Yeah.
Okay, thank you.
Jack?
I was wondering, I could be wrong, but I saw that like that they only the subjects were only recreational athletes. And do you think that could be like another limitation of the study? And if so, do you think maybe the results would be different in maybe more like athletes that are involved in more intense sports or competitive sports that like professional athletes or collegiate athletes that may require more sleep or better sleep quality?
Yeah, I agree. I think that is also a limitation, especially because um collegiate athletes and like other athletes on the elite level do need better sleep for recovery. Um but I think in terms of like other groups, for example, like the older population, because this study was done on the younger population, the journal article mentioned that there had already been studies done on like um participants who like had, for example, Alzheimer's disease or insomnia. So this was really targeting just like the younger population and also healthy athletes. But I agree. I think it could be expanded to athletes at the elite level.
Got it. Thank you.
Austin?
Yeah, Aaron, thanks for the presentation. You had stated that they had controlled for the number of caffeinated drinks that the athletes drank throughout the day. Did they also control for the timing of those drinks, as in like how late in the day they had their last caffeinated drink, since that can also impact the ability to fall asleep at night?
Yeah, I think they restricted it so that there were no caffeinated drinks past 5 p.m.
Got it. Thanks.
Yeah, I
I
also have a question. Looking more directly into how they're recreational athletes, their full-time job isn't as an athlete. Do you think there was an effect that maybe the article publishers overlooked when thinking about jobs and like what people did on a daily basis, what their routine was? Like, did they take that into account, or was that just something that they overlooked?
I think there was a variable put in like the sleep quality questionnaire, just like for any other extra comments. Like that's definitely a challenging part of these kind of sleep studies because there's a lot of variability in people's schedules. Like a lot of the participants couldn't like reach the required time of wearing the goggles. Like some people um like obviously like deviated from like the sleep wake schedules and also like just yeah, the amount of time wearing the goggles. And some people had to like really like change up their schedule to like make this study work. So I think that's part of one of the challenges of doing these studies.
Thank you. Dr. Lopez, do you have any input?
Yes, thanks so much. Obviously, um, we've been talking about the importance of sleep, maybe its impact and performance. I think, obviously we've been talking about different factors that affect sleep in subtle ways in the past couple of lectures and that. But I guess the question I have for this study, and that is, and Austin brought it up about the caffeine. I also, as we saw in the previous talks over the past weeks, we know various caffeinated drinks have it's a very large spectrum of how many milligrams per drink, or how many milligrams of caffeine are in each type of drink. So obviously they didn't regulate that. So maybe if they did have, 5 energy drinks in a can, or maybe if they went to one of the famous coffee places, we know that that's going to have higher milligrams of caffeine. So there's basically, it was kind of a little unregulated, the amount of caffeine intake per se, which if you're trying to affect sleep, I think that's probably the number one thing that they should, mitigate or attempt to take control of in a study like this. So obviously we talked about the variations of milligram concentrations in certain drinks the other weeks, and we know that that's something that could totally affect someone towards the evening hours of the day and disrupt sleep and REM. We know that. So again, did they discuss that in the limitations on how many milligrams, or the lack of measuring or knowing how each individual, obviously these are recreational athletes, right? So you can't really put too many parameters on them, but did they at least attempt to measure that in any way?
I think just in the questionnaire they only asked like how many caffeinated drinks they took per day, not really like the concentration of them.
Hmm. Yeah, that's like, if you're going to do a study like this, that's probably what number one, you know, thing I would think about that affects everyone towards the evening hours, right? All right. So on that note, another question I had was the goggles. Did they say what generation they were? Because you said that they had difficulty in using or sleeping or comfortability with the goggles, as various recreational athletes complained about them. Do you know what generation they were up to? Maybe have they started dabbling into some of the different, sleep masks, or maybe even some of the type of the fabrics? There's like the pillow eye mask. There's, a sleep blocking eye mask. Did they speak on any of that? Because that's another limitation, I think, if they were going to come up with something.
Like the generation of the sleep products, like the goggles.
Yeah, the goggles they provided them, right? Because there were two purposes, right? They were to, well, you tell us, what were the purposes of the goggles, Erin?
It was just to like um emit light into their eyes.
Block out light,
Yeah.
right? Or emit light in the morning, right?
Yeah.
So there's different fabrics. There's variations in the weight of them, right? We have weighted blankets. You guys know about those, right? Some of you may know about them, right? And they help you sleep. So I was just wondering, did they discuss the limitations on the generation of the eye goggle or the eye mask that they used? Because that's also, we see that in the variations of some of the, virtual headsets used in some of the video games, right? Generation one compared to where they are now, they're really evolved, right? So I'm just wondering, did they take any of that into consideration? Because I think with caffeine and comfortability, if you have a stimulant on and you have an uncomfortable mask, I think those are two factors that they're not calculating or, discussing the influence of those with sleep,
Hmm.
right?
Yeah.
Because that you kind of think that would be important to measure or even to, try to mitigate as much as you could. Now, how much um, light did they anticipate to penetrate in the morning, or hope that it would penetrate the fabric, or
Um, I think they mentioned specific wavelength measurements. They didn't really talk about like the generation of the products or like at least like in their selection process, they weren't really looking for like the comfortable how comfortable they were. But I can like speak on like I think they chose to do like light emitting goggles or like light restriction goggles rather than like sleep masks per se, just because they were talking a lot about like the importance of like the wavelength of the light exposure. So yeah.
hmm. I still think that, if you're trying to induce sleep, I personally think comfortability may be an important aspect. But again, that's my opinion on the matter. Obviously, if you're telling me that they complained, and then the nausea and vomiting that they got with the goggles, do we know if any of them, did they filter anyone out with seizure as a, criterion? Did they put a criteria that, anyone who had any um epilepsy, history of epilepsy or anything like that?
I don't think that was part of the criteria, or at least it wasn't recorded. I think they were really just going for healthy athletes who didn't have any sleep problems.
Okay. Right, everyone understand what we're inquiring about, right? Obviously, if you have a certain amount of the population that was tested presenting with nausea and vomiting because wearing the goggles, it's almost questionable, like they may have an underlying issue. And they should have been excluded from the data set for, or it would have validated the work even more so if they would have said in their limitations, two athletes were removed because of nausea vomiting without a history of unknown, without knowing the history of their medical history fully, we excluded that true, fully. So you just have to think about that. Yes, it limits your data set, but you have to be very, rigorous with your methodology. All right. Thank you so much. Good job there, Aaron.
Thank you, Aaron, and for everyone's contributions to the conversations. Our third intern is Jack, and he will be presenting on the sex differences and recovery trajectories. Jack, may you please share your screen?
Thank you, Kevin, for the introduction. My name is Jack Kania. I'm from Queens, New York. I'm a rising freshman at the University of Connecticut, and I'm sharing my screen right now. Today, I will be presenting on the article Sex Differences in Recovery Trajectories of Assessments for Sport-Related Concussion Among NCAA Athletes, a CARE Consortium study. And this article was written by Jason B. Kachesi and her colleagues, and it was published to a book entitled Sports Medicine in 2024. And this consortium study is actually the largest database of repeated head injuries and concussions in all of history. So, before we get into some background, the purpose of the study, the researchers wanted to determine whether female and male NCAA athletes recover differently after concussions. They also wanted to determine whether recovery trajectories are similar across multiple concussion assessments, and the researchers also wanted to determine which tests throughout the study revealed meaningful differences in gender. And so, why did they study sex differences? Previous research in the past had suggested that females may report more symptoms from concussions, take longer to recover from concussions, and also have higher concussion rates in comparable sports to their male counterparts. So, some background. A sport-related concussion, or a SRC, is a mild traumatic brain injury caused by biomechanical forces that temporarily affect brain function. And some common symptoms of an SRC are a headache, dizziness, balance issues, memory difficulties, sensitivity to light and noise, and nausea. And when got untreated, concussions can be deadly or fatal. So here's a short video on the mechanics of a concussion. So as you can see, that's a video from the CDC, or the Center for Disease Control and Prevention. And they emphasize that how important recovery is and how the brain becomes more sensitive to extra trauma and injuries while still in that recovery time period. So just the process of a concussion and post-concussion recovery. It all starts out with an SRC, which is a sport-related concussion, as we said earlier. And from that, a neurometabolic cascade occurs in the brain that leads to temporary brain dysfunction. And there are many signs and symptoms that can display that someone may have a brain dysfunction. It's normally temporarily with a concussion, unless a concussion results in some other very intense injury. So some signs and symptoms can be cognitive signs, such as memory loss, attention loss, the lack of the ability to process speed, and lack of concentration. Balance and motor signs, such as postural stability, coordination, and gait disturbances, which are basically abnormal walking patterns. There are also vestibular and ocular signs, which are abnormal or unnatural eye movements, or just an abundance of eye movements, dizziness, visual motion sensitivity, and convergence. So it could that could be specifically like if something is close up to a person and the eyes converge inward, the eyes not being able to focus on the object that's in front of them. And then there's just also symptoms that people experience after a SRC, or sport-related concussion, which include headaches, nausea, light sensitivity, fatigue, and irritability. And so clinicians and healthcare professionals use a variety of assessments to analyze and to identify these signs and symptoms. They use assessments and tests such as the SCAT-3 test, the IMPACT, the BESS, the SAC, the CRT, the King-Devick test, excuse me, the VOMS test, and other questionnaires such as psychological questionnaires and quality of life questionnaires. And then from there, clinicians put together an individualized recovery plan to hopefully have the athlete eventually return to play and return to being able to have full cognitive power. So some methods that the researchers use in the study, their subjects were 906 NCAA athletes that were 61% female, so it's a pretty even split. And the athletes participated in sex comparable sports, so sports where males and females could be compared. And the athletes were evaluated and assessed on concussions at preseason or at the very beginning of the season to give a baseline. Within 6 hours of their injury, 24 to 48 hours after their injury, specifically a concussion, at their initiation of return to play progression, so when they began to start playing again, when they were cleared for unrestricted return to play, and 6 months post-injury. And again, these are all the tests that were used to identify these brain dysfunctions. And you can see here, just for the methods a little more, that you can see that they use a wide variety of different races and different sports. So there's a pretty big sample size and large amount of data that they use to compare females and males and how they recover from concussions. So the findings, the overall results from the data found very little statistically significant differences between sexes throughout recovery. You can see here in these two tests, these are two of the tests, the best test, the BESS test, is a test that measures balance and postural ability. And then the SAC test measures cognitive function, and you can see there's very little differences and discrepancies between the male and the female groups. But however, the only test that displayed some significant differences in concussion recovery was the VOMS test, which is the vestibular ocular motor screen test. So for the VOMS results, there's only significant difference during the 24 to 48 hour time period. So you can see here in this circled part, the error bars here, these little eye-shaped bars, these are error bars that were constructed from a 95% confidence interval, and they do not overlap, showing that there is a statistical significance. There's a gap between them, showing that there is a statistical significant difference between the data. But these discrepancies in sexes disappeared very quickly during return to play and initiation. So once the players return to play, these discrepancies had already disappeared, and you can see that the error bars overlap already. And then in graph B here, you can see in the point of convergence, which is the one that we said was like when something is up close and your eyes converge inward, there was still no difference there with the VOMS test. So really only with the first VOMS test that was when there was discrepancies between the two genders, and that's when females displayed greater dizziness and visual discomfort. But besides that, it was pretty much the same for males and females. So symptom burden. So female athletes reported greater overall symptom burden, which is basically how frequently symptoms occurred, how severe they were, and how much those symptoms took a toll on the athletes' daily lives. And so female athletes reported after concussions or while recovering from concussions greater overall symptom burden, and they also reported higher symptom severity. But an important finding that the researchers wanted to point out is that they concluded that greater symptoms did not necessarily equate to slower recovery. So just because a lot of the females reported higher symptom severity and an overall greater symptom burden, that does not necessarily mean that they recovered slower from their concussions. So just a clinical implication for healthcare professionals, they should not base concussion recovery slowly on sex, and focus more on ensuring recovery is individualized based on the athlete's specific tests and their specific case. So some strengths and limitations of the article. Some strengths is that there was a large sample size. They used 906 athletes. The data was pulled from the CARE Consortium, which, as I stated before, is the largest database of repetitive head impacts and concussions in history. There was numerous assessments and tests done over a long period of time. And as I said, there was a long follow-up. They examined these concussion recoveries over up to 6 months after injury. They included a baseline of the beginning of the season as well that acted as a control group, and they had multiple measurements throughout the whole recovery process. Some limitations, however, was that there only were NCAA athletes, which means that the data might not be able to be generalized for maybe more higher level pro athletes or younger athletes, such as high school athletes or youth athletes, as there's different levels of play, different injuries that occur at different levels, and just different biological makeups of bodies overall in different age groups. And although they did compare a large amount of sports, they only compared sex comparable sports. So you might not be able to generalize it to all sports where you can't compare a male and a female group. And then additionally, the symptom burdens, as we talked about earlier, were self-reported. So that could vary based off a person, based off someone's pain tolerance or their mood, or just other external factors that might affect how they specifically report the severity and of their symptoms and how much it takes a burden and a toll on their daily life. Additionally, there was no cause and effect relationship really. This was pretty much solely an observational study, and the researchers they can't really conclude that something really caused another thing in one specific gender or just overall with the whole population, as there weren't that many discrepancies between the groups, and they just kind of observed and analyzed from there the data. So just some key takeaways to finish it off. Majority of concussion recovery patterns are similar in females and males. There aren't too many discrepancies or differences between the genders. Female athletes reported greater symptom burden. The only significant difference was higher VOMS symptoms at 24 to 48 hours after injury in females, and these differences resolved by the time athletes initiated return to play progression. So the differences in within the symptoms of concussions didn't last for a long time. And then clinicians should use individualized concussion management and treatment instead of assumptions based on sex. So just make sure if if you're a healthcare professional, definitely um, treat treat the patients based off their individualized tests and assessments as opposed to making assumptions based off what their gender is. Here's the article I used, and I will not take any questions at this time. Thank you.
Thank you for that excellent presentation, Jack. It was really insightful, and I love the information presented, and your implementation of videos was fantastic. First, can we have Natalia?
So you talked about how there wasn't necessarily a standardized testing that they used. Could having such a wide range of different tests also lead to those differences, or was there anything said that there were more differences in the cognitive testing versus like balance and stability testing? Did they mention anything about that?
Yeah, I generally saw. So they in the article they had graphs for each of the tests, and they displayed data for each of the tests. And it was pretty much the same throughout all of them, except for that one VOMS test where there was a difference. Pretty much all of the articles, in all of the graphs, excuse me, the females and males displayed like very similar data in terms of their recovery from concussions.
Thank you. So it didn't really matter whether it was a cognitive or a balance.
Yeah, it didn't really have
Okay.
too much of an effect.
Elena.
Thank you for that presentation. I know that they included baseline concussion testing at the beginning of the season, but do you know if the researchers accounted for how many concussions the participants previously had? Because I think that would definitely affect their recovery as well.
Yeah, that was definitely something I was thinking about too. They didn't mention at all in the article whether there were recurring or new injuries and the differences between the two. So yeah, that's definitely a limitation in the study.
Okay, thank you.
Dr. Lopez, do you have anything to add?
Yeah, so thanks a lot, Jack. I'm just a couple questions. They took this from their NCAA data set, right?
Yes, that's correct.
Right. So obviously they had to minimize some of the expectations, right? Because what scat are we up to now, Jack?
6.
So if the big concussion consensus group is it recommending to use the scat 6, there may be excuse me, limitations on what was encountered with the scat 3. That's one. And it minimally should have presented that or pointed that out, right, in the presentation, right? Because they're using this data set they've had, but some of it may be capable of being used, but some of the data may be outdated to be used in a study like this. Obviously, they probably did the best they could to evaluate the data, and that's something you need to take in consideration, right? This may be the best that's out there at the moment, and so they use that information from that, right? Because Scat 3 was 2012. So much, even if you did a PubMed search on concussion data over the past decade, and there's leaps and bounds on that. They took but that was so they could standardize it to bring in data from years before. That's why they probably did the Scat 3. So you should have probably pointed that out in the study as well. so people can understand that the limitations of using older data, they have to actually use older definitions or older classifications or older scats. So that's something that needs to be brought up. Because now the new scat 6 2022, but they'll probably be coming out with a new one in the next year or so. So of that note, I just want to make sure everyone understood the use of the scat 3. Then secondly, obviously, utilizing the VOMs, and I'm glad you pointed out, what happens is that, why are there differences, right? I think you dabbled into it, the big paper by Herman, in clinical neuropsychology discusses the limit, what's going on with sex and age related differences with VOM symptoms provocation following a concussion. And I think the importance to understand is we know women are be willing to answer the questions more often than men in more detail. They think that maybe there's a limitation on what they're answering, and that's something that needs to be brought up. Why are VOM scores different, right? Maybe biological hormonal differences, anatomical biomechanical factors. Maybe then we discussed, or Jack did bring up, the symptom reporting clusters, right? The females are more likely to report somatic symptoms more often, dizziness, nausea, headache. But they're also more susceptible to have false positive rates because of their potential migraine and pre-existing motion sickness factors. So you have a cohort that's susceptible to more, pathologies that would affect their symptoms. And then you're getting this, so, excuse me, I'm glad that they did comment on the VOMs and the limitations of that, but they didn't did they comment on the false positive rates potential with women?
No, I didn't see any of that.
This is all, Herman's papers 2024. This is 2025 actually. So, some of these factors should have been brought up.
Yeah.
But again, when you're the care group, how many authors were there?
I think like 7 or 6.
They're probably the luminaries in the forefront of what's going on. So they can get away with discuss limitations of discussing things of this nature. But obviously everyone can understand, right, how those VOMs can influence recovery rates, because you're thinking you're encountering signs and symptoms, but you're actually, it's just a reporting factor. So make sure you keep that in mind. All right, everyone.
Thank you.
Particularly when you're discussing vestibular functions amongst men and women. Okay. Any questions on that? Or any of the topics I just brought up? Okay. Great. Thank you, Jack.
That will conclude week 6 of the RRIPG Institute and Rugby Research and Injury Prevention Group Journal Club. Thank you everyone for attending.